So how many of you are undergraduate students? Okay, and graduate students? I'm sitting right here. So some of the things I might be bringing up will be possibly very foreign to you. But what I'm going to do is give you an idea of patients if they came into a hospital setting, sort of their course of treatment through a couple of scenarios. If you have questions, please feel free to interrupt in the middle of what I'm asking so I can clarify things. Okay, so you know who I am. Oopsie. This is a little bit of my work experience. I started in the clinic setting. I've been in skilled nursing facilities, acute rehab, outpatient clinics, pediatric ICU, just sort of on subacute. So it's a whole gamut. I've sort of been everywhere and done that. More with adults than with children, but I have worked with children also. So most of these are exclusively adults that I've worked with. And the adult population can go anywhere from people with traumatic brain injuries, people who've had strokes, voice problems, swallowing problems because of either physical difficulties or dementia. So if you're going to be in a medical setting, you may have the opportunity of seeing a lot of different things. So right now, I'm just going to talk about our first case. DG is a 46-year-old male. He had a history of hypertension. You know what that is? Okay. DM, you know what that is? Diabetes mellitus. He's diabetic. And a history of an MI 2 years ago is he had a heart attack. So this is not, he's kind of asking for a stroke. and he was smoking. He was smoking, but he quit after smoking for 20 years a couple of years ago. So he was at work at 10:45. He was in a meeting with others, noticed he was having trouble answering questions, and he kept rubbing his right hand. And he said, you know, I'm just tired. I don't know why I'm acting this way. Finally, at 4 o'clock, he went to see his boss, and the boss noticed he wasn't making sense, and he was limping. So he remembered hearing about FAST, F-A-S-T, and he called 911. Do you know what FAST stands for? Face. So yeah, so if his face is asymmetrical, if he's drooling, the arms, if he has weakness on one side, the speech, if his speech is slurred or not making sense, and then T is for time. So he was called, 911 was called. He was admitted to the emergency room at 5:30 and evaluated by the stroke team. CAT scan didn't show any acute bleeding. The MRI was done, which showed changes in the left frontal and parietal areas. And then TPA could not be administered, and he was admitted to ICU. So there's a few foreign terminologies in there. Oh, here we go. So FAST stands for, as we said, the face, arm, speech, and time. Why was the CAT scan and the MRI different? The CAT scan is like an X-ray, and it will show if there's any acute bleeding. If they have an aneurysm and there's actual bleeding in the brain, they'll see that first. But it may, if they had an ischemic stroke, which means, you know, a blood clot was going to be cutting off blood, they may not show anything because there's no real changes in the brain yet. The CT picks up like bone and the topography more than it does tissue changes. The MRI is a magnetic resonance imaging, which is magnetic fields and radio waves that will find those nuances that we didn't see in the CT. TPA stands for tissue plasminogen activator, big words. It's a protein that breaks down blood clots. It's the most marvelous thing that I saw in my career. If somebody comes within, if they know when you had the stroke, So when did this guy have a stroke?
Around 4.
No. It was in the morning, 10:45. It was in the morning, people were noticing he wasn't quite right. It's just that he was in his office, nobody noticed till 4 o'clock. But he didn't get to the emergency room till 5:30. So from 10:45 to 5:30, and we're out of the 3-hour window, which they could give it. If somebody wakes up and they seem to have had a stroke, you can't give it to them because you don't know when that stroke was. Was it 5 minutes ago or 6 hours ago when they first went to bed? But they give TPA through a vein, and it just busts the clot. It disintegrates it. And I've seen such miracles. The people that come in that look like they would have a very significant stroke, walk out the day after, but maybe a little bit of weakness in the arm, but it like resolves in a lot of cases. Not 100%, but a lot of cases. So this is a picture of a CAT scan and an MRI. So I guess Sean kind of animated this for me. What a CAT scan does is it shows like slices of the brain. So starting at the top, you see parts of the brain as you go down. The CAT scan picture that I showed, it shows you where there's damage to the brain. The top one is going to create a Broca's aphasia, and the bottom one is going to create a Wernicke's aphasia. You know the difference in those two aphasias? So Broca's, huh? Olive. So Broca's, there is not a fluent type of aphasia. They really struggle to get the words out, and it's much more stop and start. Wernicke's aphasics will talk your ears off, but it may not make any sense at all. They have trouble with understanding what you say, so they're very hard to redirect a lot of times. So those are just 2 different types. So the MRI looks similar, but it's done with the magnetics. Okay. So what happened when he went to ICU? He couldn't move his right side. His speech did not make any sense. He did not respond to directions. He was drooling, and the nurses didn't know if he could eat. They gave him a communication board to communicate with them. You have that in your packet. So this, they gave him this communication board. Would this be useful for him in the ICU if he's not able to? Oh. Oh no, I was pointing to the yeah, I'm not good at reading. So just because a lot of times when people are in ICU, the nurses, the doctors, whoever, just gives them a communication board saying, oh, they can't talk? Here, they can communicate with us with this. However, communication boards are very tricky. You have to know what the person is capable of doing to know what kind of communication board to give him. So it may or may not be appropriate for them to give that to him. So when he was in the ICU, a neurologist, the primary physician, a pulmonologist, who's a lung doctor, evaluated him. He was on telemetry, which means they're monitoring his heart rate, his blood pressure, all those things, and a pulse oximeter on his finger. Have you ever gone to the doctor and they put that little ET thing on? That's your pulse oximeter that measures how much oxygen you have in your bloodstream. And then he had a physical therapy eval, an occupational eval, respiratory therapy for his congestion in his lungs. Social services looked at him, nutritional services looked to see how they're going to feed him. And would a speech eval be appropriate at this time? No? He's drooling and nurses don't know if he could eat. Who's going to help them figure out SLP? So yes, it would be a good idea for SLP to come and evaluate. Can you do a standardized test? No.
No.
In hospitals, standardized tests are rarely done in the acute area because you usually have to get in, get out, find out what their major difficulties are and address those so that they can move on to go home as soon as possible. Would you do speech language eval? You take note of it, but the primary thing is his swallowing. Everybody wants to know what he can eat, so that would be the first thing you would be addressing. So here, he tolerates working with this SLP bedside for about 30 minutes. At the initial phase, the majority of the evals are for swallowing, for dysphagia. So how do you test his swallowing? First, clean his mouth. Why do we do that? What does that mean? What difference does that make?
You don't have good oral hygiene, it contributes to aspiration.
Not exactly.
The bacteria that colonizes the
Yeah, so if you have a dirty mouth and you do aspirate, it could create, I'll accept what Sean said, create the aspiration pneumonia because the bad bacteria is getting into your lungs. If you have a clean mouth and the good bacteria gets down and there's other factors that we can talk about, you're not as likely to get pneumonia from it, though you are actively aspirating. Yes?
When you say clean his mouth, you mean outside or inside?
Oh, inside. Aggressively inside. Not just a little toothette, those little sponge things. Right. Just kind of go over his teeth. That doesn't count. Yes, a lot of in ICU or in the acute hospital, a lot of them have the little toothette with suction, so you're getting things out for them at the same time. You would do an oral peripheral exam because you want to see what he's able to do with his mouth. You might do a trial of ice chips. Why would I start with ice chips?
Activates the swallow.
It may have to activate the swallow.
Because it's not running down water.
Okay.
Sure.
It's made of water. If water gets into your lungs, is that going to make a difference? You get too much, it would, but our body is made of water, so if you get a little bit into your lungs and other factors are in play, it's sort of a benign way of doing it. Interestingly, in the ICU, no, in the emergency room, when people come in, the nurses give them 3 ounces of water and say, here, drink it. So you don't know if they're able to swallow or not, but that's their test. If they, okay, I'll go here. What would they be doing that the nurses might decide we should get a speech eval? They give them 3 ounces of water, coughing, drooling, yes, filling out of his mouth. The cough doesn't necessarily have to be right then. If it's a little bit delayed, he may be silently aspirating. He doesn't have that trigger that all of us usually have to cough right away. But by the time it's gotten past the level of the larynx and getting into his lungs, he can have a wet cough. Yeah. Okay, so we gave him his ice chips. And then if he's doing okay with that, we might give him a trial of pureed, soft, and hard solids. Pureed is easiest, like mashed potatoes. Soft food would be like meatloaf maybe, or soft peaches, canned peaches. Hard solids would be crackers, steak. Then we would try to see what he could drink. There's a choice of nectar thick liquids or honey thick liquids. Nectar is sort of medium thick. Honey thick is like honey that goes very slowly, and thin liquids is just regular water, milk. For safety, a lot of people will give them the thickened liquids, but the trend is more to get away from that. Because they may not get enough hydration, they won't give them enough water. Plus, it may contribute or not delay an aspiration. So if you have thin liquids, there's something called the Fraser water protocol. which means if you wash their mouth, Joy, do you know that one? It looks like you know, Fraser Water Protocol.
Yeah.
What is it?
Well, so you do oral hygiene, it's, you're allowing the patient who has possible dysphagia to drink water 30 minutes after meal, between meals, but they're doing it with their guidelines. They're not doing it just drinking water. They've been evaluated before, they're going to move with their strategies, with their SLP recommendations.
Right.
So they're allowed to drink water, but they follow strict rules to ensure that it's still safe.
Right. And the strictest rules are you can't have it during a meal, and you have to make sure your mouth is clean. But the fact that you're coughing and choking and sputtering while you're drinking it, they go, yep, you're aspirating, but it's not going to be as dangerous for you. So the trend is to sort of go towards that a little bit more. Then you would make the diet recommendations to the physician. You would consider a modified barium swallow study. You know what that is, everybody? Okay. So you go to X-ray and they can see what's happening in the oral, pharyngeal, hopefully esophageal phase also, to see what's really happening, because bedside you administer these things and you think they don't look like they're aspirating, so you give them a diet, for instance, and then they keep recurring with these lung infections. Maybe they are silently aspirating, so you might be missing something bedside that you would need to have an instrumental. Or we have a choice of fiber optic endoscopic evaluation of swallow, the FEES. Do you know what FEES is? In the modified barium swallow, you're sitting in X-ray, and they just take an X-ray and they give you food. The FEES, they put a flexible tube down your throat, down to see what's happening at the level of the larynx. You see the little epiglottis and all these fun things. And they could see if you're aspirating or what the swallow looks like inside with that. The FEES is very sensitive if there's microaspiration. On a video swallow study, the modified barium, it may not really show the little black line up going into the trachea for aspiration because it's so subtle. But the FEES will show how things are spilling in, and over time you can get pneumonia or have more difficulty. So we talked about signs why you might be aspirating. We talked about why should we want to be also, jumping ahead a little bit, the modified barium swallow, the people have to be transported down to X-ray. The FEES is done right at bedside. So if somebody's in ICU or in the subacute unit, it's really a preferred thing because the nurses, the family gets to see real time what's happening, and you can give the recommendations, and you don't have to take them out. If they are in the ICU and you're taking them for a video swallow study, the nurse has to go along with them. It takes time. It's hard for them to tolerate. So there's all kinds of factors that go into it. So if we're assessing his speech, language, and cognition, first we want to see what his alertness is. Then you do some language comprehension screening, his speech production, dysarthria, praxia, you know that. Verbal language screening, reading comprehension, written language comprehension. Observe his cognitive responses, like his attention, memory, problem solving, reasoning, visual deficits, pragmatics. So how do you do all this? Well, page 2. In your handout, I gave you some information about swallowing. That's what this page is. It gives you some ideas of what you might be doing to help with swallowing. And then there's also I have to admit that I borrow and use things from other facilities, but this happens to be Northridge's sort of acute screening form. But it'll show you how you go through looking at all these different things, and it's just a quick photograph of where it might be having problems. It's not in-depth comprehensive. Once you decide where you're having problems, you would do more in-depth evaluations. So I guess, did everybody see that? Forward. Okay.
We have this.
Yeah, so that there, I'm giving them as references. If you don't really need to worry if you don't have it, as long as you don't have it, we can get to it.
So just so you guys know, we'll be emailing out all of this information too here, so don't worry too much.
So now DG is stable after 2 days in the ICU, and he was admitted to the acute stroke unit of the hospital for inpatient therapy. So now the SLP is going to see him still bedsided in his room. They might get him out of bed and into a chair. He's more or less, you're in his room doing therapy. You're continuing to work with his swallowing safety, that he's getting a little bit better. So you begin more aggressive speech and language treatment if that's indicated. And he can work for about 45 minutes with the SLP. So his tolerance and endurance is getting a little bit better. Working in the acute setting, the acute hospital floor, is challenging because he's busy with nursing care, being sent to tests, out for radiology, 35 visitors who come to see him, and can you do it later? So it's really difficult sometimes, and there's no planned time for treatment because there's so much going on in the hospital that you just, it's sort of catch can, so it's sometimes frustrating. But the beauty of it too is that you get to train the nurses and the family that are most important in knowing what your goals are to follow through. So after 5 days, he is better, he needs less nursing care, and he's transferred to the acute rehabilitation department. So if you're going to acute rehab, that's a distinct, it may be a floor in the hospital, it may be an outside facility, but the rules are you have to have at least 2 of the 3 main rehabilitative services. So you have to have PT and OT or PT and speech, or all 3 to qualify. You have to be able to tolerate at least 3 hours a day. So that would be an hour of speech, OT and PT, and recreation therapy, and anything else that comes along. If PT and OT are working for an hour and a half, and you're the 3rd person, so that's like 4 hours of therapy, but they have to have some endurance. He will get therapy 5 to 6 days a week. The rehab disciplines are more collaborative with some co-treatment sessions, like having a cooking group or a games group. What do you think OT and speech would be doing in a games group? Why are we playing games? John?
I don't think it's for playing games, but you're working on communication and fine motor skills at the same time.
But people are seeing you playing bingo. They know bingo, and they say you're playing bingo. So yes, it's a legitimate game. However, you are assessing and working with those skills. The PT or the OT is working on, can he use his weak right hand to place the chips? The ST might be looking at, does he have a field cut? Does he comprehend what he's seeing? Does he hear the numbers? So in a simple activity like games, there's a lot of your expertise that goes into assessing where the problems are and making decisions what you could do to help facilitate success in those areas. Yes.
In that scenario, can they bill for OT and speech for the same person at the same time?
Yes. But they, like if the games group is for an hour, they each bill for a half hour. So they're not double billing, exactly. But you also, the OT and the speech has to not look like the same note because you have different expertise. If it looks like we both did the same thing, then they'll pick one or the other. So it has to be very distinctly occupational therapy based or speech pathology based. So now he's being seen for either 30 minutes twice a day or 60 minutes once or twice a day. And you're coordinating with everybody else. The therapy may be in his room. It may be in a public area like a game, day room, that type sort of thing. You may go out to the unit, go to the gift shop, and see how he does in situations like that. And you want to do therapy that's more tailored to his previous activities. If they never went shopping in their life, you may not take them to the gift shop because somebody else is going to do their shopping anyway. And then he has meetings with a physiatrist. How many of you think that's a podiatrist? A physiatrist is a physical rehab and medicine doctor that's his specialty in looking at rehabilitation. So as opposed to like a pulmonologist, his specialty is looking at the lungs, but they're both doctors. So they have different specialties in the hospital, and each one wants to assess what they could do to help. The physiatrist is usually the one that is the guiding force in the acute rehab unit. They'll have recreational therapy, because besides PT, OT, and ST, you want them to get into like their hobbies and what they like to do from a therapeutic point of view, assessing what they could do, how they could get back to card playing if they're hemiplegic, they could only use one hand. So the recreational therapist is very instrumental in doing that. They have a psychologist. If you had a stroke, would you need a little bit of emotional support? A neuropsychologist. What's the difference in that between a psychologist and a neuropsychologist? Anybody know? Any of you would go to a psychologist if you're having a little bit of emotional difficulty. A neuropsychologist is a psychologist, but he's also looking at the way that the brain problems that you're having impact how you're able to do things. So, for instance, some people after a stroke, the family says, oh, they're just lazy. Well, their stroke was the frontal lobe, and they just don't have initiation. They're not lazy, they just don't know how to get going. And so the neuropsychologist can explain that to the family and give the family suggestions of what to do to improve that. Case managers, they come in to see, where can we send them, what the insurance is. Social services is sometimes like case management. And then all the physicians that would be coming in. Any questions on this slide? Okay. So now nursing is more actively involved with the carryover. For SLP, if they're giving recommendations for swallowing, for instance, this SLP recommended that he have nectar-thick liquids by spoon during meals and turn his head to the right when he's eating. Why would you turn your head to the right when he's eating? Joey?
It goes off the weaker side. So it will
If he's, right, because if you're looking straight ahead, you have a 50-50 chance of food going either way, and you could aspirate. If you're turning to the right or whatever maneuvers you're doing that the SLP has determined increases the safety, that helps. And like Joey said, it closes off the weaker side and allows things to go down the strong side. Why liquids by spoon? There again, a lot of different people, strokes, TBIs, are very impulsive, so that you give them the cup to drink, they chug along the whole thing. If you're forcing them to take it by spoon, it's a limited amount that they're getting and they're going to be safer. A lot of times we might recommend thin liquids with spoon only, which means that limited amount they can manage, but if they're taking a big chunk of it by cup, they're likely to aspirate. Have any of you aspirated on water by drinking too fast? Yes. Yeah. Yes.
Is there a reason why they chug the water so quickly? Is it like out of a sense of desperation? Or?
Not out of desperation, it's more impulse control. That I mean, yes, they're thirsty, but if you were thirsty and the nurses or SLP said, just take a sip at a time, you can't wait to down that whole cup of water, but you would take a sip, but they just can't inhibit their wanting to do it right away. Okay, and then we said he could have thin liquids between meals if he brushes his teeth. We talked about that. Family is given specific training for discharge to home. A home evaluation may be done to see how things will really be in the home. Usually several disciplines of therapists go to evaluate the home. If somebody is very cognitively impaired, but physically okay, it may be the speech language pathologist and the occupational therapist that goes to the home eval. Usually it's the physical therapy and the OT because they want to see how you navigate around the house. So it doesn't say it has to be PT or OT necessarily. And if there's any modifications that need to be made to the home, they would make those recommendations there. If it's a cognitive person, I want you to read my mind, but I won't make you. What's one thing that you could do to help them cognitively? Sometimes they lose track of what day it is, so just making sure that they have a calendar in a place that they could check off what days and you can establish a routine. The family doesn't realize that sometimes, but that's something you might discuss in a home eval. So acute rehab is usually 7 to 10 days, and you have weekly team conferences to discuss the progress, share information, solve the problems, and the plan for the discharge. DG's discharge was scheduled after 12 days, but his destination was uncertain. Patients are discharged from ARU or from any place, the acute hospital or outpatient, not when they're all better, which the family wants them to be, but when they've learned the skills necessary for somebody else to carry on who is unskilled. Unskilled doesn't mean they don't know what they're doing. It just means you're not a licensed speech pathologist. Which, speaking of that, when you're doing documentation, you want to make sure that you put documentation that shows that you are licensed, that they need you to help this person. If you just say, I help the person say words, does that show that you are skilled and that a speech language pathologist is necessary to work with this person? Anybody can help them. But facilitated mouth position should produce initial phonemes. Does that sound like you know what you're talking about? Yeah. So, you know, you wanted to make sure that your documentation reflects your skill and expertise in the area of speech language cognition. So if DG could go home by himself, if he can't go home because there's no one around to help him, he could go to a skilled nursing facility because he still needs supervision for safety and assistance with taking medications. Therapy there is the same disciplines that are available, but it's at a reduced frequency, intensity, oftentimes. Some insurance companies use the skilled nursing facility for their rehab. So you might see a 35-year-old stroke that's in there because their HMO had a contract with that skilled nursing facility, but they would only be there for a short period of time and then move on to home or someplace else. The caseload in the skilled nursing facilities is often related to chronic problems like failure to thrive, respiratory issues, premorbid neurological issues, and treatment for dysphagia, management, cognition issues, and functional communication. So you might have somebody that's in there that broke their hip, and all of a sudden the nurse or somebody goes in to see them, and now their face is drooping and they can't talk. So they may have had an acute CVA, but they're there for a broken hip. So they would go out to the hospital and come back, and then the speech pathologist and the rehab team would be actively working on the rehab process because they're a new stroke and you want to give them as much rehabilitation as possible. Or if he can be sort of on his own, but he needs some assistance, he might go to an assisted living or boarding care home. This is where he has supervision and just needs a little bit of assistance. He would have his own room. The SLP would go and do therapy there, or he could have home health services there. mean, that's what it would be. Medications are monitored, and he gets help with bathing and dressing. And he's out with other people so that he can participate in activities like music and art, doing things that he enjoys. So it's a little more social than being at home with nobody around. Or he could go home with family and friends who will help him. And the doctor orders the home health services, which will have the nursing, social services, and therapies following. That's awesome.
Could you explain the difference between assisted living and skilled nursing facility?
Skilled nursing is where you need a lot of nursing care. So the nurses are the predominant person. In assisted living, you have your own little apartment. They have a nurse on campus, but they have aides that help you to make sure you get down to breakfast and help you in the shower if you need a little bit of assistance, but you're sort of on your own. Okay, so home health is ordered, and he can stay with home health as long as he's homebound, which they sort of define as he could go out to doctors, but he can't go out to the store or go anywhere else. I think they actually allow you to go to the hairdresser and the doctor. And aside from that, you're considered homebound. So in home health, the therapist will give sort of a ballpark. I think I'll be there around 3 o'clock. It's like an hour leeway because you're driving from home to home. If you're in a large area, you're going between Tarzana, Santa Clarita, Burbank, all in a day. They may be seen 1 or 2 times a week for maybe 30 to 60 minutes. So it's usually not very intensive. The therapy could be challenging in the home because the kids are demanding attention, the TV's on, you don't have a clean table and easy access to materials. Your office is your car because you have to carry everything with you. And but the home is great because you see what their natural environment is and could really help them. And hopefully the family is there and you can educate the family at the same time. However, some families decide, oh, good, babysitting service is here, and they'll go around, go off and say, oh, you're going to be here for an hour. I'll be back in 55 minutes. And you lose the impact of educating the family. So DG was no longer restricted to home, and he has more stamina after 3 weeks, so he's referred to outpatient rehabilitation. So an outpatient, he has an evaluation, probably with all 3 disciplines. He may be seen 2 or 3 times a week for about an hour, or whatever is determined by the team. In outpatient, the team would get together and discuss his current status, the weekly goals, how we can support each other in therapy. For instance, the ST might be using constraint-induced therapy. Do you know what that is? Okay, it's like putting your good hand behind your back and forcing you to use your weaker hand. If you have a hand that can work and a hand that doesn't work, you're going to be doing everything to make it easier and faster with your good hand. But that's one of the things OT would use where they restrain it. So you can't use your good hand. And so if you're turning over the cards, you have to use your weaker hand. And so that's how we would incorporate it into your speech pathology session, because you know that this is what OT wants you to do. So you're making them do the same thing. Likewise, OT or PT, you want them to give initial phoning cues to say what they want to say, and they will make them do that for counting when they're doing their reps, whatever stage they're at, to support your goals. His swallowing is improved. Usually in outpatient, you don't see as much dysphagia, but if you do have a dysphagia patient, you might do neuromuscular electrical stimulation. They're known as VitalStim, but there are other companies out there. VitalStim is most known, probably. Do you know what does neuromuscular electrical stimulation look like?
stroke.
Yeah. Right, you have electrodes that you put on different places, either the face or the neck, that help the different muscles to be facilitated in order to swallow. It's not, PT has the TENS unit or electrical stimulation, where you put it on, you relax, you enjoy it. Neuromuscular stimulation, the vital stim, does not work unless you're actively swallowing. So you're placing those electrodes and you make them swallow, whatever it is there. They can be swallowing their saliva. It doesn't have to be food. But that's, it really, because the theory behind it is that it puts the muscle in a state of readiness. So when you swallow, it really kickstarts so you get a hard swallow. So now in outpatient, the focus is more on his communication skills. The duration of treatment is recommended by the SLP to the physician. However, insurance plays a big part in outpatient therapy. So depending on if they have Medicare or a PPO, which means they might have more unrestricted number of sessions, or an HMO that has a certain number of sessions. My favorite was always somebody that was very obviously aphasic, minimal physical problems. PTOT had 10 visits on the initial eval 10 visits. Speech had eval in 2 visits. So that just means that you do your eval, you make your recommendations, and then you have to ask for more. I don't understand why they do that, but it's very frustrating when you know, everybody knows that this is an aphasic patient. He needs you more than me, but they're chitsy with our visits. And then Medicare and Medi-Cal, they all have their rules for specific documentation. For Medi-Cal, you have to do a TAR. For Medicare, you need to do your initial eval and have that submitted to Medicare. And then every 10 days, you have to do another assessment report to get approval. With something like the PPO or the HMO, they may say 24 visits. You should be letting the doctor know that you don't have to have a report to request more therapy until 24 visits have passed. But Medicare is very stringent. So you would continue therapy as long as approved by the physician and it's medically necessary. Medically necessary means, why are you as a speech language pathologist necessary to help them to recover? And you see significant progress. A lot of times, things have changed, but we used to have a cap system in Medicare. So the first 10 visits, you don't worry about too much. And then you reach an area where they don't want, you really have to prove your worth, or they won't approve it. And so many people reach the 3rd tier of the cap, which means they're likely to get refused, that Medicare will not pay for them. And so that discussion might come up where they're not making enough gains to justify keeping them, but the family wants you to keep them on. But maybe it's only February and you've used up all your Medicare dollars. You have to wait till next January for that Medicare money to come in again. It's too much information. It's the real world.
It's real world.
It's the real world.
Yeah, it's devastating.
Yeah,
At that point.
it's frustrating. Well, I'm sort of on an insurance thing, I'm off track here, but it's hard when, like, you have a young traumatic brain injury who, he went to Cal State Northridge. He didn't really have insurance because I'm healthy, what's going to happen to me? I'm 19 years old. He has a traumatic brain injury and he has no insurance. And so you in your heart, you want to help them, but whatever agency you're working for says, if we're not getting paid, you know, insurance doesn't cover it. I'm sorry. Not gonna get covered. Anyway, I diverge a lot. So in the outpatient setting, you might do therapy in a nice quiet office or outside of an office or in the community to maximize their life participation in normal activities. People may do very well, you know, they come to your room. I would always say, they would say, well, I do so well in here. And I would say, I don't have magic fairy dust in here. You can do just as well outside, but they don't carry through with what they need to do on the outside. Or it's so quiet in my room, they have few distractions, but if they are in the gym and they try to do the same things, it's too distracting. They can't concentrate and it disrupts their ability to do whatever you're working on. Treatment is scheduled, so you know when you're going to see the person. There's a stronger therapeutic relationship established because you're seeing them frequently and the intensity of the treatment. The families and caregivers are encouraged to participate in therapy to support the patient for the homework you give them. In the acute hospital, you may not be giving much homework, but in the outpatient rehab, you're always, if you're seeing them only 2 days a week, you give them activities, things to do to carry over those skills at home. If you've never been in physical therapy, they give you a regimen of do these exercises when you're not here, because that way you'll continue to progress. The sad thing sometimes is I would see people for outpatient therapy and the attitude of the family would be, well, I bring them to therapy, why aren't they getting better? Because you're not doing anything at home to help them. They don't force them to talk or do anything at home. They just put them in front of the TV again because, well, we can't really carry on a conversation anymore, so yeah, watch TV. And then they wonder why they don't get better. So by the time they're outpatient, the progress may be a little bit slower. They say the first 6 months, 6 months to a year, oftentimes doctors say if they're not better after 6 months or a year, you know, that's all the better they're going to be. Don't believe them. It's slower, it's more subtle, but people progress if you keep working at it. Obviously they do. You'll see that in our LPA group. So maybe slower. So in acute rehab, let me go back to acute. In acute, the person just had a stroke, and so you might go, oh, they really couldn't do much of anything, you know. So you go into that mindset of this is what I'm going to do in therapy, but wow, they're better. So it's vital, especially in the acute hospital setting, to be extremely flexible and know what your goals are, know what you want to work on, and change what you're doing at an instant, because you know that's what therapy is all about, that flexibility. Oftentimes people will report that once they were discharged from outpatient therapy, they all of a sudden got a lot better because they're just in their regular lifestyle, they're doing their regular things, and they're stimulating their life participation on aphasia. They're doing what they need to do. But when they're in therapy, oh, there's something wrong with me, I have to go to this therapy. Just sort of a little mindset thing that I've seen. In outpatient, you're collaborating with the other rehab disciplines, teachers, employers, community settings, families and friends, to establish modifications for the client to succeed, integrating back to their preferred activities. So if they are able to go back to work, you want to sort of inform the administration where they work. You may need to have a private office instead of the office with 6 people because he's too distractible. If they're able to accommodate, then you know things will be marvelous. And then after formal treatment ended, he was referred to the CSUN Life Participation Approach to a Patient Program for continued real-life exercise in his communication with others who have had neurological injuries in the past also. So that it's, I'll brag about our program. It really makes a huge difference. And we have seen people when they're able to communicate with others who understand that have gone the same path, they've had a stroke, they are motivated to talk with each other, they encourage each other, they find out that they can talk more than they thought. And I've had many family members saying, you know, they never used to do this, but they're so much better. You know, they're trying to talk when they didn't try to talk before. That's a miracle for us. We want to see that. Okay, commercial over. Case number 2. HW is a 24-year-old male riding his motorcycle to finals on a rainy day. The driver did not see him, and HW hit the car, was thrown about 50 feet. When witnesses checked on him, he opened his eyes. His speech was not intelligible, and he moved his arms. His arms were pulled up into his chest. How does he sound? So he's sort of like this, or something like this. There's a fancy name for that. They say they're posturing. They're like this, or they're like this. It's a kind of posturing. This is decorticate, means there's major brain damage. Decerebrate means there's even more deep brain damage. So if you, so the EMTs arrived about 10 minutes, and they looked at his Glasgow Coma scale to tell the hospital. You have a copy of the Glasgow Coma scale in there. What level would he be on the Glasgow Coma scale? So you look at his eye opening, his motor activity, and his speech. Add up the numbers. So what would his, if his eyes are open, what number is that? 4. Okay. His speech was not intelligible, so probably a 7. And his arms were pulled into his chest with posturing. It would be arm flexion. So he might have a moderate here. So he went to a trauma center. It was evaluated by the team. He had multiple fractures of pelvis, clavicle, ribs, and femur. The CAT scan showed a large depressed skull fracture with an intracranial hematoma in the front right parietal lobes. He went for surgery. So he went for surgery for craniotomy. Craniotomy means that they replaced a part of the skull to access if there is bleeding, which he had a hematoma, so they want to evacuate the blood. And there's another reason you might do a craniotomy with somebody. Your skull is a closed bowl. Your brain is jello. If you are, no, that's not a good example. Your brain is a balloon that when you have swelling from a head injury, it wants to get bigger because it's getting swollen. Where is it going? You only have this much skull, so it's going to either be pressing against the skull, or if that's used up, where is it going to go? Down to your brainstem. You can't live without brainstem activity. So, you know, you could die easily if you don't have that. And it's really strange to see, because you have a skull, but then their brain may be swelling, and so you see this little lump on their brain. So you look like you've seen that before. Oh.
Grossed out.
No, I get very excited about it. Yeah, you know, it's just there. And this is exposed brain, and if they've shaved it, it's exposed brain, and you see it pulsating, because it's getting blood flow. Exciting. And then they might have a shunt put in so that the edema, the swelling is reduced. And all of a sudden you have the brain, this is the coolest thing. he had the craniotomy. They put a shunt in, and this guy was scratching his head, and his hand went in there. It was so sunken in because the swelling had gone down. You have to be a medical speech pathologist to get to find this exciting. Anyway, those are the kinds of things you might see. And at the ice, yes.
What do they do with the piece of the skull?
They may put it into your stomach to incubate while you're waiting to have it put back in. Or if it's so damaged, they may put a titanium plate in there. But while they have that craniotomy, they're not allowed to get out of bed at all without a helmet. Because if you just accidentally bump your head straight to your brain, not good. So, that's a hassle that people don't like to have to put on their helmet to go to the bathroom or anything like that. So he had an ICP, an intracranial pressure monitor, placed to see how much pressure is in his brain. He was on a ventilator, a breathing machine for him, with an endotracheal tube, which means the ventilator went straight into his mouth, and an oral gastric feeding tube. Since we have one tube in there, we can put a feeding tube that goes down to the stomach in as well. Again, he was on telemetry with pulse oximeter. We explained what all that means. So when he recovered, what cognitive or communication or swallowing problems might you suspect? If he had a frontal and a right parietal problem. Sean?
Do you have executive functioning and cognition problems?
Yeah. Anything else?
Laryngeal stage, but it's right-sided, tends to be laryngeal stage, left side tends to be oral.
Yes.
I remember the slide with class.
For swallowing, yeah. But also, are we going to see aphasia necessarily? Where is the aphasia usually? It has to be on the left side. However, when you're in a motorcycle accident, you have the coup concuque. He may have the problem on one side, but this is where the jello and the bowl come in. His head went this way, and maybe it was fractured here, but it also bounces back, so you get that whiplash kind of thing. Simple car accidents where you have whiplash injury can cause brain damage also. Just saying. Yes.
I'm sorry, what did you ask? You said, what does that mean? I missed what part you were
For the right thing, what does that mean?
Joy?
Oh, yeah, I'm not sure if that's really reality, but there's some evidence to support that for left-sided TBI versus right-sided TBI or stroke. I'm not sure that if it's left-sided, swallowing problems tend to be in the mouth, maybe, and if it's right-sided, swallowing problems are more posterior.
I don't know if that proves out. I don't jump to that necessarily. Hannah, were you saying?
Yeah. How common are injuries to the vocal cords with like other intubation periods?
Good question. So the intubation means that the tube is going down through your vocal cords down to your lungs to give you air. If it's in there for 3 weeks, do you suppose you might have some irritation and damage to the vocal cords? So if they're intubated for a long time, oftentimes there is vocal damage, hopefully temporary. But and that is why if they figure out that you're going to need a ventilator for a while, they will give you a tracheostomy. And so the ventilator comes here, bypassing the vocal cords, so it's not going to harm it. But if people were intubated for surgery or anything, they may have voice problems that take a while to recover.
Okay,
Yes.
I had one
for 6 hours during surgery one time, and I woke up the next day and I just could not talk. at all.
Yeah.
Yeah, and it just like hurt really bad.
Yeah, it's like a bad sore throat.
Yeah. It went away, but it did hurt a lot the next
Right.
day. Yeah.
It's the swelling, it's irritation. Some people are more sensitive to it than others, but, you know, just like you said, for a 6-hour surgery, you sometimes see that as well. If it's in there for weeks, you're more likely to be more prolonged and possibly have long-term damage.
Is it long-term damage? What's like the average time for a fistula to form?
For fistula to form
Yeah.
from laryngeal damage, that would be more, it may form, I don't know that there's a prescribed, I mean, a day, I don't know, but if you're making damage, but what will create damage a lot of times is if you had what they call a cuffed trach. There's different kinds of trachea tubes. There's an uncuffed trach, which means the trach tube that goes down into your throat. If it's uncuffed, it's just the tube into your throat. If it's a cuffed trach, you have the trachea tube, but there's a little balloon around it, and you can tell if the balloon is blown up by a little puffy balloon over here. If people are aggressive and puff up that balloon, and you know, I'm going to make sure this is really firm. Okay, it's puffed up, it's firm. That's creating damage to the trachea, and that often causes a fistula over time. It's pressure swelling, exactly. Yeah. Yes.
Since the trachea, since the trachea is like an open tube in the back, if you overinflate the cup, can it like push the trachea away from the esophagus?
It doesn't push it away from the esophagus, but it would push into it possibly. But I mean, it's just not a good thing to do.
Yeah.
And it does cause a fistula. Another exciting thing. What's a fistula? A fistula is a hole between the trachea and the esophagus. A little bit off of what we're talking about, but I had a laryngectomy, total laryngectomy patient. What does that mean? His larynx was completely removed. So where is he breathing from? He has a permanent hole in his throat. That hole goes straight down to his lungs. So eating is, you know, the esophagus goes straight to his stomach. The trachea, the stoma, the hole in his throat, is just an open trachea down to the lungs. So I'm feeding this person, and the daughter said, I think she's having trouble because I think she's bleeding. Her little cloth that they put there keeps getting red. I think he's bleeding. No, it's the color of Kool-Aid or red Jello. So when she was eating, it was an undiagnosed fistula. She would eat, but the Jello went into her trachea, and when she would be coughing, it was leaking out. That's a fistula that they didn't know about, that I discovered for them. That you know, that's how you know. There should be no communication if you have a trouble laryngectomy. Okay, off the top,
Heal by themselves, or do they need something?
they often heal by themselves, but you have to take away all stimulants, or they could do a stent, you know, where it's like a little supportive tube. Yes.
So is that considered aspirin or
For her, yes, it was grossly aspirating. Because anything that's getting into your lungs is considered aspiration. So, have any of you aspirated? Little fun fact, you probably all aspirate at night. You probably all aspirate in your sleep, but it never affects you because you're in good condition. Here I'm going on another tangent. What is Halloween? You know. talked about the good oral hygiene, the oral care. What are other reasons why you might be aspirating, but you won't necessarily get pneumonia from it? Yes?
Good hydration, proper immune system.
Good hydration means you won't get pneumonia? Not necessarily. I mean, having a good immune system and hydration is great, but if you,
Walking around. and active.
yes, if you're ambulatory, if you're able to walk around, if you're active, getting out of the bed into the chair, if you feed yourself, we see this a lot in nursing homes or in ICU or anything. If the nurses are feeding you, where are they? First of all, they may not prop the bed up. So they have you laying down. They're putting food in your throat. They're watching Oprah while they're doing it. They're shoving it in because, oh, I only have 10 minutes to feed you. So they're shoving it down. Are you ready? We did a really cool example for the certified nursing assistants in the nursing home. We fed them the way we see them feeding their patients. And so we gave them, hot fudge sundaes. What more can you want? So we're feeding them and we're talking to each other in Spanish if we're, foreign language, not paying attention to the patient, and feeding them. And you can see them go, like, okay, let's, you just ignore them. The next day, we had so much change in the way that they were doing it because they realized that you have to look for that swallow. Just because you say open their mouth and they open it this much, oh, there's nothing there. Well, there's all kinds of food in here, and they haven't swallowed yet. So, tangent. Okay. Back to target. So this would be the CT scan. The example I gave, see on number 4 for the skull. Remember, the CT is an X-ray, so it's showing bone. On the higher views, that dark area shows you where the hematoma would be, because that's where the blood is in. If you go to number 3, the ventricle is sort of obliterated. You should have 2 even-sized ventricles, but it's smaller. Number 4, the skull doesn't look like it's good and solid anymore. That's where maybe a depressed skull fracture. We had fracture of the skull there. So he was in ICU for 12 days.
Go ahead.
Oh, I just. Oh, okay.
She's fascinated. How far apart are these scans?
They're the same day.
Wow.
It's just the different layers that you see. Number 1 would be the highest layer. You don't see too much up there. But then when you're getting down, number 2, number 3 is even darker. Means you're getting into where the infarct or the bleed is more. Other questions? It's all from the top, right? Yeah, CAT scans always start, slices, millimeter slices down, and they put together a 3D image of what the brain looks like, but it's actually just a plane of the brain each time. Okay, so you had everybody under the sun seeing in neurology, pulmonology, ENT, that's ear, nose, and throat, who gave him a tracheostomy, gastrointestinal or a G-tube, neurosurgeon who did surgery, infectious disease. If you're intubated, people who would have oral intubation are likely to get infectious disease, MRSA, whatever the superbug of the month is. So often infectious disease doctors have to come in. They're evaluated by respiratory, dietitians, social services, PTOT, and speech therapy. What would you do to evaluate him now? So we knew that his eyes might open up. He was not talking. He's intubated.
See, we can get eye blink communication.
Jade, would we give him a communication board?
Potentially like eye gaze, but first you can see if he could like blink twice on command or that kind of thing,
Yeah,
right?
I see. I mean, from the picture I painted, it doesn't sound like he's alert enough to really do much of anything. So while he was in the ICU, the endotracheal tube in his mouth was replaced by the tracheostomy. His oral gastric tube was replaced by a gastrostomy tube. He could not sustain wakefulness. He followed people with his eyes, but didn't follow commands. He was trying to pull out his tubes. You have the Rancho Los Amigos behavioral scale is a scale they use with traumatic brain injuries. I think you should have a copy of that. What? It says Rancho, no?
It's another packet.
So look at, from the description and what's there on the Rancho Los Amigos scale. If he's not very wakeful, he will follow people with his eyes or sort of gaze intermittently. And he's not following commands, but he's pulling tubes. What level on the Rancho scale does it look like he might be? He's like level 3, which is just a generalized response. He's not pulling the tubes because he doesn't want them there. It's just an irritant. If a fly walks on your arm and you scratch it, do you realize that you're really scratching it? He's pulling at things and reacting with, I mean, it's a localized response, that's right. Just there's something irritating him in a certain area, so he's just trying to get rid of whatever's there. Pulling out catheters, pulling out G-tubes, whatever. So for the G-tubes to prevent that, they sometimes put a binder around because then they can't get to the tube because you have like a big bandage girdle around there, so you can't get to it. Okay. So then he was transferred to the medical surgical floor for medical management. Speech therapy was reassessed him and found he was more alert. He had some reflexive responses, like opening his mouth when they washed his lips when they were doing oral stim. He might have a rooting reflex, or he was just opening his mouth. So at least he was more responsive. So dysphagia therapy was initiated, as well as the language and sensory stimulation. So does it mean we're putting him on a diet right away? No, we have to do a lot more to prepare him to be able to eat. After 8 days, he was more awake and active, trying to climb out of bed, trying to hit the nurses, occasionally following commands, and appears to be mouthing words sometimes. He has a tracheostomy, so he can't really talk because there's no air coming by the vocal cords. So is he ready to start a diet? He may be, he may not be. He was evaluated by a physiatrist, again, a rehab doctor, who recommended a subacute placement. First of all, look at your Rancho scale again. If he's trying to climb out of bed, more awake and active, hitting nurses, what Rancho scale is he now? So he's coming up in the world. He's at level 4. Level 4 is the hardest one to deal with because they're so active. They may be physically, verbally, whatever, abusive, but they are not responsible for what they're doing. They're just reacting to it. I've seen people that the nurses put them in a chair and they strap them to the chair for safety, and next thing you see the guy in the doorway with the chair strapped to his back, and he's up and at him. So, they're hard to control. 2 things in ICU or just anywhere to manage somebody that's very hard to manage physically like that. What do you think is easiest for nurses? Yeah, they give them medications to put them sleepy time all the time. If you're sleeping all the time, are you able to respond to things? No. You have to work through these levels. If they sedate them, they're going to stay at that level longer, and because they're not able to work through it. You have to manage them working through it. So a lot of times they might have a sitter with them. Somebody's physically sitting with them, and as soon as they start to get up, give them a verbal or physical cue, lay down. That way, you're allowing them to work through things, but that you're keeping them safe at the same time. So there's a picture of the diet there. What kind of diet might he be on? This is a pretty this is a pretty puree diet because it's soft, pudding-like, but the peas, they made them look like peas. The meat, they made it look more like a piece of meat. The potatoes. But so they're getting very sophisticated. In the hospital that I was in, if they had meat, they would make it look like a pork chop. It was still soft. I mean, it crushes with the fork spoon. It's still puree, but it's formed, which is nice. So he's transferred to the subacute. To qualify for the subacute, he requires constant nursing care. He has to have a tracheostomy or on a ventilator and have a G tube, a PEG, which is sort of like, it's the same as a G tube, the NG tube, nasogastric tube, a J tube, the jejunostomy tube, which means the gastric tube goes into your stomach, the jejunostomy tube goes more like into your intestines, you're bypassing the stomach, or needing TPN, that's total parenteral nutrition, which is like they put it into a central vein. You're getting nutrition through the bloodstream, not through any gastric system. So somebody had, if his gastric system was destroyed, he might have TPN just to give him nutrition while he's recovering. But in the long run, you don't want to do that for the long term because you want them to be able to use their normal stomach intestine system.
Why would they choose to place a J tube over a G tube?
It may be because of damage to the stomach or, that, again, precautionary. We as speech pathologists often say, oh, they need a G tube. And then the physician gets terribly upset with us saying, he can't have a G tube. You cannot say he needs a G tube. You can say he needs supplemental needs of nutrition, but the physician has to determine what kind of damage they have. So if he had problems in the stomach.
With the J tube, is there less risk of aspiration?
No. Yeah.
How easy is it to put someone on a tube, and how easy is it to take it off?
So like a percutaneous enteral gastrostomy tube, it's just like a pinprick. They put a light through, ET light, find out where your stomach is, do a little pop, put the little tube in there, and you have a tube.
Sorry, that's not what I meant.
Oh.
What I meant was, how easy is it to like prescribe someone, or like,
Oh.
and how easy is it to like say like they don't want it anymore, the family doesn't want it anymore? How hard is it to take that away?
You can prescribe whatever your professional opinion is. If they're really unsafe, you would recommend that they could have alternative nutrition. But it's always the family and the quality of life of the person that you have to take into consideration. You may recommend a tube, but the family says, no, I'm going to feed them. In that case, even though you think they should not be eating, you might be saying, well, if you're going to feed them, the safest thing might be to do these maneuvers, even though they're going to aspirate. If you put in a tube and the family decides, we just don't want to feed him, they have the right to pull it too. But sometimes that's not respected. and it stays in. When I started on my other thing, so it's easy to do in the G2. I had a guy who was a traumatic brain injury, shouldn't be eating Friday night, that I saw him. Monday morning, I said, you know, let's wait for a few days. They put in a G2 Friday night because, oh, he's not eating. Monday morning I came and he's eating hamburgers. He was a traumatic brain injury, he just wasn't alert enough to eat. But so they put in a tube, maybe a little prematurely, and now he's eating regular food. So can we just say, oh, just pull it out? No, we have to wait 6 weeks because I don't know exactly the medical reasoning behind it, but if you have a tube, you have to have it at least 6 weeks and then they can pull it, otherwise it does damage. So yeah, so he had a G tube that they would push water through just to keep it unclogged, but he was eating by mouth. Yes.
Is it safe to eat regular food with a tube?
Yeah. You can eat anything. The tube is just there to provide nutrition so that you can maintain your health. But oftentimes people have a oral diet along with tube feeding, and you want to just sort of wean them off the tube feeding and have a more oral diet. Which, if they're giving them tube feeding, you're making them full, and then they're saying he's not eating his lunch tray, and you say, yeah, but he's getting all his nutrition. If you were stuffed, would you want to eat anything? No. So you take him off the feeding tube, or say don't give them feedings except at nighttime or after meal, and you find out they start eating because they have normal hunger, but they want to eat their meals. That's how you get them to eat the diet. Okay, so he's in the subacute. The SLP is going to work very closely with respiratory therapy, nursing, PT, and OT to progressive swallowing communication. So the top picture is like a picture of what a G tube would look like, where it goes in your stomach. And the bottom picture is just a dummy, but it's the tracheostomy you see in his neck. And they're putting an NG tube into his nose to go down to his stomach. So HW was there for a month. ST got another evaluation request. And this time, he was found to be confused and inappropriate in his responses. He was usually calm, but would get agitated when overstimulated. Is he appropriate for typical therapy at this point? Would you pick him up for therapy? But he's confused and inappropriate. Can't we do something with that? We want to orient him. We want to control his environment. We want to teach people how to work with him. He's following directions. He just gets confused. He's functioning at Rancho level 5, which is the first level that you could really do traditional therapy with them. He's able to routinely participate in therapy for about an hour. The SLP was able to progress HW to a speaking trait, passenger valve. We talked about that, or we didn't. So we have the, sorry, keep me on track. So he has the tracheostomy tube, but if you just have a trach, then you can't speak. They sometimes speak around the trach. The air gets by the tube and can innervate the vocal cords. So you hear some sounds, but they're not really able to talk theoretically. The speaking tube is, or the passing air valve, is a little button that you put on the trach. And it's a one-way valve, so they can breathe in freely, but when they breathe out to phonate, it closes off, so the air is forced to go by the vocal cords. So now they're able to talk. So a lot of times, people may have that long term, or it may be a step to see if they're able to tolerate that. The next step might be they want to plug the trach. They just keep it plugged where you're breathing through your mouth and your nose only, not through your neck. And then if they're able to tolerate that, they may pull it altogether. So 2 weeks it was plugged and it was removed. Yes. Yes, absolutely. Why do you think? So if you have an open system, it's hard to get the pressures needed to swallow. But now you have a normal system, it's closing off just like when you're talking. You're able to get the pressures and it reduces the risk of aspiration. And it really enhances the person's ability to swallow safely. Okay, now he appears to have an interest in eating and drinking and respond to oral stimulation for eating. So the SLP wanted an instrumental evaluation of swallowing. What would you suggest? What?
Because he's still in the, well, he's in subject, and then he's also gets agitated. It's like they bring him down to do the X-ray and getting his
That would be my test of choice.
I also want to see the tissue quality clearly, which feeds allows for like to see the quality of your tissue, and whereas MBSS is just an X-ray.
Yeah, if you're concerned about the tissue, yeah.
That would be after all this stuff. But maybe honestly, I just think
No.
it's been thrown by.
You may not see much because you see everything all the way from when it hits your nose and goes down. You see all the tissue going down. If somebody had, no. If somebody has something, an infection, you would see blotchy patches or something wrong in the tissues. But yes, if he was intubated, you would maybe see that the vocal cords aren't really coming together. It's a separate evaluation from what the otolaryngologist does. You're not really assessing vocal cord pathology, but you would see things and report to the doctor saying, you know, we saw something really strange on the piece. He has this huge bump and it's irregular and it's red. What do you think it is? So you refer back to the doctor for them to assess, because we cannot make medical diagnoses, but we can sure give them a heads up of this is not normal. So yeah, and the fees, as you said, is easier, but it's not something that is easily available in many hospitals. It's the gold standard. They're both gold standards. But I find in more community hospitals, they don't have fees available, but in university hospitals, teaching hospitals, that's one of the things that you would encounter quite frequently. And you would be working side by side with the ENT. So there's, behind the scenes, there's all kinds of issues that come into working in a hospital, community hospital versus what we wish it could be. Okay, so the physiatrist reevaluated because we recommended it. He was admitted to the acute rehab unit where he stayed for 3 weeks. He participated in the therapy. He was now at Rancho 6. He was still improving. He was placed on mechanical soft diet with good liquids. G2 was removed. He had severe left neglect with poor awareness of his deficits. That's not unusual with the right CDA or right brain damage. His speech was clear, not unusual with the right brain damage, but his problem solving and executive functions were poor for novel activities, or just about anything. With structure and cues, he could perform simple activities of daily living, like feeding himself. He had some inappropriate behaviors and difficulty controlling his temper. He was able to walk with standby assistance, which means they're just sort of there in case you need him. But he was not safe with physical therapy because of his distractibility and impulsivity. Those issues impact physical and occupational therapy a great deal. They may be physically okay to do things, but if they're distractible and impulsive, they become very unsafe. And so all 3 disciplines would still be working aggressively from different points of view with those issues. He had no immediate family, and his girlfriend could not stay with him to help him on discharge. He wanted to return to living independently, but he couldn't be discharged home safely. Bummer. Yes.
It's mechanical, soft diet.
Oh, it's like, it's altered ground. Like a soft diet would be like meatloaf. A mechanical soft diet would be the meatloaf is ground up. So you still have to chew it some. It's not pureed like pudding.
It's like ground or chopped.
Just ground and chopped, yeah. So it was recommended that he continue his rehabilitation in a residential neurological recovery program. In the residential program, he will participate with rehab therapies and all the supportive services that he had in acute rehab. He lives like in a dorm type setting, and there are 24-hour rehab aides on to be there to assist him. They continue to train him with self-care activities like cooking, laundry, arranging for his own transportation, and during the day, working hours, the rehab disciplines will work with him, but the aides work with him after hours. So at 8 o'clock at night, if they know that he's supposed to be doing a certain thing that the therapist recommended, they make sure that there's consistency, that they do it all the time, as opposed to, I go to therapy and then I just don't pay attention to anything I have to learn. So it's really a 24-hour integration of all the therapy that he needs to master. So he'll go out on outings like shopping, to the movies, bowling, and he'll learn how to deal with unexpected situations with the external stimuli that he's getting in those places. If he's distractible and impulsive, he may try to get off the escalator too soon, or the band is playing in the mall and he just is too distracted, he can't pay attention to what he's supposed to be doing. Did you have a question? So after 6 weeks at the residential program, he went home to live with his girlfriend. He attended the outpatient neurological day program now. So now he's back into a day program where he gets therapy like 5 hours a day, but he goes home at night and lives with his girlfriend because he's able to be managed better. A year after his accident, he started taking 2 classes at community college with assistance of the disabled student department, who provided an aide to assist him with note-taking, and he was permitted to take his exams in a different room due to his distractibility. So there's a successful outcome to this because he's getting back to college. Maybe he wasn't doing what he did before, but he is being trained and able to do something different. A lot of times you want to, all of you want to feel like you have a purpose in life. And so getting people into a reason for living, doing something, is a major goal in therapy, because you don't want to just get better to sit home and watch TV all the time. Emotionally, it helps you so much more. Even we would have a lot of people volunteer because I have to get up, I have to be there, I do something. One girl was volunteering at the Gentle Barn, which is a animal rescue place, and her job was to clean up after those goats and clean out, menial kind of job, but she had a job. She wasn't getting paid for it, but she had such self-worth because she was doing something functional. So with all this in mind, if this was a 45-year-old person, might the outcome be different? Why? Motivation. He's older, like 55, you're in the prime of life.
I'm just thinking about
You're not that old yet.
my dad is around that age, so I don't know if he would be like, get up and get ready. Like I feel like he wouldn't be.
Actually, I'll put this in. If you're 55, it might even be more devastating because you're in your prime earning. You probably have kids in college that you want to be able to support. It's really, from that point of view, just as traumatic as being somebody younger.
I was just thinking that because he was 19 when he had his accident, so So 20 by the time, so he would still qualify for school services. So
We said he was 24, this guy in the
he's
accident.
24 now. Oh, I thought he was 19.
No, he had the
Sorry.
accident when he was 24.
Oh,
But what are those little neurons like? Neuroplasticity. When you're 24, you always have neuroplasticity, but it's just like if kids, when I would work in the peace trauma, they would have devastating accidents, but they, by the time they were in middle school, just had a little bit of deficit because they can recover quickly because of neuroplasticity. The older you get, it just takes a little bit more time, and you may not be able to bounce back as fast, but there is neuroplasticity at any age. As long as you're stimulating the brain, you can continue to improve. Okay. So case number 3. LL is an executive secretary for a large medical company. She was walking her dog while texting a friend, did not see the uneven sidewalk, and fell straight down on her face. Her neighbor saw her, came to check on her, and found that LL was dazed and a little slow to respond, but she denied being hurt. The neighbor talked her into taking her to the ER just to get her checked. In the ER, she complained that her head hurt and was evaluated with no significant neurological findings. The CAT scan was unremarkable, and she was discharged home with instructions to just take it easy for a day or 2. So then she went back to work. After about 2 weeks, she was at work, but she said, the lights are so bright in here. Why do they pump up the lights? She lost track of what she was doing sometime. She seemed to get irritated quickly. You know, she was always so mild-mannered, but now, you know, she was snappy. She didn't remember the names of some of her contacts. She complained she was tired and a little dizzy sometimes, but it was probably because she wasn't having trouble sleeping. So should she report that to her doctor? Why? What might be happening? Yes, Josh? It could be, you know, just like Carter had a bump on his head. And if you listen to the news, he just went in for evacuation. He had a bleeding on his brain. That was like 2 weeks ago that he hit his head, and they just discovered it. So yes, bleeds can happen from just a little bump on the head down the road. So you need to look for neurological signs. But this was not significant. There was no bleed. Do football players ever have damage? Do you get in a bad accident? Do you feel disoriented? Mild traumatic brain injury? So all of those kinds of things that she was experiencing, the sensitivity to light, her not being able to sleep. You have a handout in your handouts that talk about some of the symptoms of mild traumatic brain injury. It's things that we all might complain about at some point in time, but people around would say, oh, she's just, you know, she's just taking advantage of saying she got hurt. So there's nothing wrong with her. And people are often not given justice in knowing that this is an actual injury that needs treatment, because everybody gets tired. You know, if I get up too quickly, I get dizzy. So these are all symptoms that you can kind of slough off as not being important. But considering she hit her head, you want to pay attention to that type of thing. So, want to know anything else? Any questions? She did go to the doctor. And she insisted because her friend was a sleep pathologist and said, we need to Yay. Yeah.
What is treatment for
It would be like, you know, like a tension test, and the same sort of treatment you would do, but it would be very subtle, higher level. But it's you do the same types of treatments that you might do somebody that has memory problems.
a lot of these people just choose not to get treatment and
They may, because they don't, it's not well published now. Because of football injuries, it's getting more noted that there is such an entity as a mild traumatic brain injury. And so people are getting acknowledged for having that more. But most of the time, spontaneous recovery, if you have an injury, you usually get a little bit better anyway. So these symptoms might go away. But if you notice that I can't concentrate like I used to, I can't, remember the facts for my test like I used to. That's something different where you can mark that there was an injury and now it's not the same. It's not in your head. There's something wrong. Yes, it is in your head. It's in your head, but it's not.
Also,
Not
does
your
she have
head.
poor deficit awareness?
No, she really didn't have poor deficit, but it's all those things that can happen to any of us. And she doesn't, if you're not attuned that there is something called mild traumatic brain injury that causes these issues, you just think, oh, I'm tired. I don't know why I'm not sleeping. All these things that we can just discount. Just like for stroke, if you feel like, oh, my arm is tingly, it's asleep. Oh, I must have slept on it wrong. Is that a TIA? Is it like a mini stroke? Or was it just you slept wrong? You kind of don't realize these things that you have, symptoms that you experience intermittently may actually be significant as a medical event that's going to happen. Yes.
Would there be a difference in her injury when she fell on the back of her head? Or is there no difference?
What do you think?
I think yes, but the first thing I thought of was maybe her eyesight, because it would be possible, but then it does say that she has sensitivity to the brightness, so
That's good thinking. Yeah, if she's hitting the back of her head, she may have more injury to the occipital lobe and have more visual issues. But it's that coup contra coup. It's those little tearing and shearing of the neurons that is not visible on testing, but causes those issues. Because she hit the front, she may have more executive function types of things. She hit the back, maybe there's more visual, but it's more of a diffuse brain injury, not so much like if there's a bleed or if you get shot by a bullet. It's very specific, the area that was affected, aside from the swelling. But these diffuse brain injuries sometimes can be very devastating because everything is disrupted, but nothing really shows on the CAT scan and MRI because it's all micro tears and issues, nothing significant to treat. Okay. You all want to go to the medical field now?
Yeah.
Yes. Okay, thank you. Available for questions at any time if you want to get me. I'm down in the neuro clinic on Monday through Thursday mornings. Just come and by and say hello. Okay. Thank you. Rocket Club.
Is there any
Yeah.
need to decide which project? Okay, thanks. Does anyone have a highlighter list?
Oh, and join us for our Fall Fest next week. Yes. This time, 5:30.
Oh, she got it?